And good morning, welcome back. Glad you're here. So we talked about sympathetic blocks and several topics yesterday, and we recorded them for podcast, but it got 10 minutes of it, so I'll try to get that re-recorded today. Let's go ahead and dive in. So we start with a question and see how we do, and then we'll talk about the information on the back side of it. So the intercostal nerve does not have motor innervation. True or false? So people, once again, this is a poorly written question because it has a negative in it. Sorry about that. So there is no motor innervation as part of the intercostal nerve. People have said that that is true. So actually there is motor innervation with intercostal nerve. You get the three muscle groups of the intercostal muscles, but those are only accessory muscles to breathing and not particularly important. So if we're going to go in and ablate the intercostal nerve, we don't really lose much doing that. So we can't really do like a nerve root ablation in the cervical spine or in the lumbar spine because you have pretty significant motor innervation of those areas. But if we go in and destroy an intercostal nerve or deaden an intercostal nerve, we don't really lose a whole lot. So that is a bit of a tricky question. Yes, the intercostal nerve does supply motor innervation to the three layers of the intercostal muscles, but it's not really anything that is physiologically significant unless you're a significant COPD or and you're using your intercostal muscles. So the reason why we're talking about this is because it was a keyword that in the last couple of years we have not done well on. So we want to reinforce the information about that. So the intercostal nerve is the nerve root of the thoracic spine. Now here's a piece of information for you that I want to get away since I'm not doing acute pain. I was going to say hardly at all, really not at all, is whenever you're doing an epidural for acute pain, universally, whenever you use blind technique, you are going at a lower level than you think you are, okay? So, Brandon, come on. So, whenever I'm examining our fine doctor's spine here, his thoracic spine will start right here. This is much higher than people believe that it is, okay? His cervical spine will end right here. Whenever I'm doing a cervical epidural, I have patients all the time say, "You didn't do an injection into my cervical spine." I said, "No, I did. It just comes very far down in the thoracic cage." Why is this important? Because if this is where T12 is, and you think that that's a different level, then you're not placing your catheter at the proper spot. So whenever you're going to go in for a T10 epidural, you need to be about here. This is where sometimes people place epidurals for thoracotomies, and then they don't work well. Here's a rule of thumb. If you're going to miss on an epidural, miss high. Why? Because you're trying to block the ascending pain pathways. So if you're a little higher than you need to be, that's fine. If you're below where you need to be, what do you have to do? You have to use volume to push up into the level where you need to be, and you get a much denser motor block below than you really want. If you land at the exact right spot, thank you for coming up. If you land at the exact right spot, you can run an infusion of 2 cc's an hour, and the patient will often never push their button, okay? So, and all this is the experience of having done this under fluoroscopy. You start to realize, hey, people's thoracic spines start way up, a lot higher than you think they do. So whenever you're going on OB at what you think is, you know, L1, L2, L3, you probably are lower than you think you are, okay? So go higher in the thoracic spine. All that to say, that reminded me, each of these thoracic dermatomes is just a nerve root that comes around. Just like the L5 nerve root or the L4 nerve root, you get this dermatomal band. And remember, this is a key point. Most of the seniors understand this, but people who are a little lower in their training don't appreciate this. You go from C4 to T3 or T4. You have a real sharp dermatomal band here, and that's why patients who start to have numbness and tingling in their fingers, you'll be checking their level here, and they're here, but it's creeping up, and the next thing you know, you've got respiratory issues with your catheter. So you go from C4 to T2, T3, T4 down in here, and it crosses right at the collarbone. Why? Because the other dermatomes go out the arm, and so you have this sharp demarcation right here where you're pretty high cervical and thoracic. Now, we have these cutaneous branches that come out and give us innervation of the skin. We also have motor branches. It's real common for us to go in and deaden an intercostal nerve for abdominal pain or after thoracotomy. And we can get away with that because the motor innervation, while it is present, is not particularly important. Okay? With each intercostal nerve runs the vein and the artery. It is a radicular pain pattern. People get burning and dysesthesia across a band or down into the abdomen. Okay? The block is often done blindly. You just walk off the inferior aspect of the rib and angle up, and that works pretty well. You want to come out here sort of on what's called the angle of the rib. We try to, when we use fluoroscopy, we'll pick it up right there as it comes off the spine because it's a little more reliably placed. Ablation is possible since it is a sensory nerve and motor has little discernible function. Okay? Beating that dead horse. Spinal cord stimulation, and I need to change this quick, but spinal cord stimulation is for axial low back pain, meaning mechanical low back pain. True or false? There have been more and more questions about neuromodulation, spinal cord stimulation, and a lot of chronic pain questions have been showing up in places, and so that's different. So spinal cord stimulation is not in the traditional sense for axial low back pain. It is for what? Neuropathic pain of what origin? Radicular pain. What else? Okay, so a complex regional pain syndrome type thing. There are two other indications for it. What are they? No. I mean, that's a syndrome, but so a lot of times diabetic neuropathy, and in Europe it's actually used to treat angina and vascular symptoms. Why? Because the sympathectomy that you get with spinal cord stimulation, the functional sympathectomy, increases blood flow 300% to the extremity. So let's talk about spinal cord stimulation. The concept of spinal cord stimulation is this. Currently you are wearing a shirt. Yes, everyone is wearing a shirt. You feel your shirt now because I have mentioned it. You think about it. But were you thinking about it a minute and a half ago? Only if you're really into fashion. And none of you look like you're into fashion. Well, a couple of you do. But your blue scrubs are great. Okay? So, what happens now that I mentioned your shirt, you felt it, it drifts to the back of your mind. Why? Your shirt isn't bothering you. It's not noxious, right? So your brain, it's one of the millions of signals that your brain is currently receiving, or thousands of signals, let's say, that your brain is currently receiving that it ignores to keep you from going insane. Honestly. So your brain can focus on 3 to 4 things at a time. If you're a guy and you're married, your wife would say that may be optimistic. And so you then are able to move things to the back of your periphery so you can focus and concentrate. Pain is a noxious signal. So whenever we have a painful pattern, if we can cover that painful pattern, let's say my hand is the painful pattern, with a non-noxious stimulus, the brain can then forget about it. Does that make sense? That's what spinal cord stimulation does. It places a tingling sensation called a paresthesia that is not noxious over an area of pain so that then the brain can forget about it. Remember, chronic pain is different than acute pain how? Acute pain signals you that there is some sort of tissue damage or trauma that's going on. Chronic pain is a signal that is self-perpetuating without any functional benefit. So if it can be covered up, we can move beyond the problem. We don't make it go away, we just cover it. And that's what spinal cord stimulation does. It uses a paresthesia or a tingling sensation that the patient does not perceive as noxious to cover up a noxious stimulus. Okay? Now, any questions written about spinal cord stimulation are going to be a little bit difficult for you to answer because in the last 6 months there have been new platforms that have come out that are paresthesia free. They are high frequency. And so high frequency stimulation, you can't feel it. It's so fast the nervous system cannot discern it, but you still depolarize the nerves deep in the spinal cord, blocking the pain sensation. So it has a different mechanism. And that has been shown to be significantly more effective for axial low back pain. So traditionally, the reasons to put spinal cord stimulation in have been radicular pain, diabetic neuropathy, complex regional pain syndrome, and vasculopathies, including angina and peripheral vascular disease. We are moving into an era where we may be able to apply it for things like mechanical low back pain and failed back surgery syndrome. So when you put it in for failed back surgery syndrome, as Dr. Gish mentioned, you are placing it mostly for radicular symptomatology, and the patient will still say, wait, don't do about my back still hurts. And you usually end up prescribing a medication of some sort. So what does spinal cord stimulation do? So this is the epidural space. This is the ligamentum flavum. This is the what? The dura. The leads are setting here. This would be analogous to your epidural catheter. Here we have the dorsal horn of the spinal column, and this is CSF. Okay? So CSF volume is important. The space between the dura and the CSF is important for spinal cord stimulation. The more space there is, the more this electrical field has to travel. So we use electrical wires, we use these electrical leads to create an electrical field that then impacts the dorsal horn and depolarizes it, the descending fibers. Okay? Now I'm going to depart from spinal cord stimulation for a few minutes and talk about something that's slightly more germane to anesthesia, so bear with me here. What are the, let's pretend this is not stimulation and electrical, but we have a catheter here and we're infusing medication. What are the structures that must be traversed in order to get medication to the dorsal horn of the spinal column, right? Because we're trying, if we're giving neuraxial analgesia, we want to impact the dorsal horn. If we give opiates, we will be trying to get opiate to what Rexid lamina from yesterday? 125, yes, great. All right. So what are we trying to do? What structures do we have to get medication from this catheter to that dorsal horn? What do we have to traverse? Anybody? Dura. What else? Subarachnoid. What else? Pia. And what else? CSF. Okay. Then you have the material of the dorsal horn, which if it's white matter is mostly fat. Okay. Of those structures that I mentioned, what is the barrier to diffusion of a medication? Anybody know? Anybody have a guess? What is the biggest barrier to diffusion of medications? Reuptake? We'll give you positive reinforcement, but that's not correct. Anybody else?
Size.
Size of the molecule?
Yes.
I'm asking really which of these anatomic structures, including the CSF, is the biggest barrier to diffusion? Sorry, let me re-ask the question. Anybody? Dura, okay, that's a common. Anybody else? CSF? It's actually the subarachnoid. So the subarachnoid mater, even though it is like tissue paper, is 3 to 4 cell layers thick with tight junctions. Okay? And so that is the biggest barrier to diffusion. Okay? Dura is actually kind of like paper towel. You know, you can pour water on a paper towel and it starts to have water seep through it. So dura is actually pretty porous. It's very tough and fibrous, but it's rather porous. It's the subarachnoid mater that is the biggest barrier to diffusion. Now, whenever I give an opiate in the epidural space, let's say I give a lipophilic opiate like fentanyl, okay? I give fentanyl in the epidural space. What is the goal of that? To get it to the dorsal horn for neuraxial analgesia. When you give fentanyl in the epidural space, what is in the epidural space? Fat. Epidural lipophilic opiates like fentanyl and sufentanil are rapidly absorbed by the fat. At 20 minutes, systemic blood levels are the same from an epidural bolus as from an IV bolus. So whenever you give epidural fentanyl and epidural sufentanil, you get analgesia. It is just merely systemic in nature. You get less diffusion across because of the rapid uptake from the epidural fat. It's just something to think about. That challenges many of your assumptions. Many of you are going, there are places where we do fentanyl. We won't say it on the podcast. So it's just something to think about. And this is a well-established fact that you're not getting neuraxial analgesia. You're getting analgesia. It's just systemic in nature. So the goal is to get opiate here. When you give it intrathecally, what happens? Fentanyl will stain the outer layer of the dorsal horn, whereas morphine will penetrate pretty deeply. But morphine has other issues. Morphine will penetrate and it will go up and down the CSF, whereas fentanyl stays really peripheral. Whenever you have a catheter here and you're trying to create analgesia, you're really numbing up nerve roots. Opiates go to dorsal horn, local anesthetics anesthetize the nerve root out here. Does that make sense? Okay, now we can go back to spinal cord stimulation. Back to this. We create an electrical field and we impact the dorsal horn, depolarizing it. So you can create two different size fields with your electrical leads. Okay? Anybody have any questions about what I talked about intrathecal pharmacology or epidural pharmacology? It's very, just challenged a few of your deeply held preconceived notions. The work of Christian Bernard's, he did tons of work on this area. CSF. Does CSF circulate or oscillate? How does CSF move around the spinal cord? Is it like a big lazy river? Woo! Back up to the brain? No. It oscillates. As the heart pumps blood, the brain expands, and there's this up and down motion that is consistent with the cardiac rhythm. So CSF does not circulate. It has areas of very little motion with oscillation, some eddy currents in there. So whenever morphine gets to the brain, it is diffusion through CSF. It is not some sort of a lazy river of scooping up morphine and depositing it. Fentanyl will stay at the level you place it. Morphine will move significantly because of its diffusion characteristics. Here is a spinal cord stimulator lead. We have 3 leads in place over the midline. It's for neuropathic pain at present. That's changing. Mechanism is unclear. We think it's depolarization of the descending columns. It's done by trial, and you have a permanent implant. Hopefully that will get the questions that are on spinal cord stimulation. Intrathecal drug delivery has only 3 medications with FDA approval. Which of these combinations, and this does show up, which of these combinations are approved for intrathecal administration via a drug delivery device? Excellent. We think baclofen must be right, correct? Either that or I really just screwed up the question. All right. So then, bupivacaine, does anybody have an idea what ziconotide is? Other than Dr. Gish, maybe Dr. Seelbach, who's thinking about doing chronic pain. Anybody know what ziconotide is? It is a snail toxin. Sounds great. Let's put some snail slime in our spine. It is a snail toxin that is an N-type calcium channel blocker which modulates pain fibers. Okay. Is bupivacaine FDA approved for intrathecal administration? Everybody thinks it is, raise their hand. Everybody who thinks it is not FDA approved, raise their hand. Bupivacaine is not FDA approved. Whenever you give bupivacaine in the epidural space or the intrathecal space, you are giving an off-label medication. In fact, bupivacaine is what? This is the guess what I'm thinking. Bupivacaine is neurotoxic, as is lidocaine. They are myotoxic and neurotoxic. Sounds like a great thing to use in a block, doesn't it? So whenever we place these medications with vasoconstrictors that keep them around longer, sometimes they cause nerve irritation in and of themselves. So bupivacaine is not FDA approved, ziconotide is, and it's between morphine and fentanyl. Nobody bit on fentanyl, so morphine is approved. So why are all these medications, hydromorphone, fentanyl, why are these medications that we use not FDA approved? Anybody have any idea? Costs millions to approve a medication. Nobody's going to do that for hydromorphone. The only reason they did it for morphine is because 30 years ago when they created intrathecal infusions, they had to have a medication to put in it, so they studied it with morphine. So that's good. Baclofen for spasticity. Baclofen works on which receptors? GABA B. There's GABA A, GABA B. Baclofen B. Baclofen B. Your Verseds, your midazolam, they work on GABA A. If you remember, baclofen is GABA B. Everything else works on GABA A. It's a way to remember that. So intrathecal drug distribution, you get, whenever you give a medication in the spinal fluid, how is it cleared from the body? Does it just sit there forever? No. It's slowly reabsorbed. 30% of the drug concentration in the CSF will be systemic, so a very low amount. So if I give 200 micrograms of intrathecal morphine in the spinal fluid, I'll have about how much in the systemic fluid, if it's 30%. Yeah, 60. But that's 200 micrograms over the course of 24 hours. So that's 60 micrograms systemically over 24 hours. If I gave you an infusion of morphine, 60 micrograms over 24 hours, do you think you would feel it? Unlikely. We get calls all the time. You know, we got a patient down here in the ER. You got to come turn this pump off. They've had a mental status change. And I'm like, work them up for stroke. You know, it's not the intrathecal pump. If we've placed it with our dosing strategies, it is not the intrathecal pump. Even if there's a milligram, is 200 micrograms given over the course of 24 hours anything that you'd even notice? No. TENS unit. For some reason, we don't understand TENS units. How does a TENS unit work? Remember our gate control theory of pain yesterday that we talked about? If you hit your thumb with a hammer, what do? You grab it and you rub it. So a TENS unit merely activates the cutaneous sensory receptors, thus providing a distraction like stimulation does. It covers a painful area with a non-painful stimulus, closing that gate that we talked about yesterday. Does that make sense? That is the whole way a TENS unit functions. Now, whenever I talk to patients, they'll say, so is a TENS unit kind of like a spinal cord stimulator? No, they're very different. It's a very different phenomenon, but they work by modulating the gate control theory. And that's what I said here, so I feel good about that. That's wonderful. I love it whenever what I said actually matches what the slide says. All right, Botox. Botox works by In reality, Botox works by stimulating the financial benefit of dermatology practices. That's how Botox works. But biochemically, it interferes with acetylcholine release. Okay? Acetylcholine release. Let's take a look at this. More questions are coming about this. Here is a vesicle of acetylcholine. Okay? And so we have to get it from the cytoplasm to the membrane to be released into the synaptic cleft to bind with the acetylcholine receptor. Okay? The way this happens is a protein on the vesicle is like a handle called synaptobrevin. I don't expect you to remember that, but do remember the SNAP25 protein. So you have syntaxin, which is the anchoring sites on the membrane, and you have synaptobrevin, which are on the vesicle. We have to lock these together. And what is it that locks them together is SNAP25. This protein connects the handle to the anchor. Does that make sense? Syntaxin to synaptobrevin is SNAP25. Botulism toxin cleaves the SNAP25 protein. Okay? So you don't get neurotransmitter release. Okay? So by inhibiting the release of the transmitter, that section of the muscle goes flaccid. So whenever I inject Botox into this area, these SNAP25 proteins are cleaved, and then this area of the muscle is flaccid. So if you have a trigger point, you can inject it and you get a flaccid muscle. So that bound up area of pain is flaccid. Let's explain what that means. Well, shoot. I think we're going to come back to that. Complications of a trigeminal nerve block do not include, boy, I write bad questions, don't I? Which of these do you not get with a trigeminal nerve block? Yeah, something's gone tragically wrong if you're getting pneumothorax. I kind of just wrote that for a joke. So, right? But let me tell you, I feel perfectly confident that a fellow could do almost anything. So that doesn't surprise me. Trigeminal neuralgia. You still read in textbooks, carbamazepine is the first line of treatment. That is the nastiest drug. I mean, you have to check all these labs, and I mean, Lyrica and gabapentin seem to be a lot cleaner, but carbamazepine is the first line agent still. Local anesthetics blocks, and you can do neurolytics. So you go up the cheek and into the trigeminal nerve, or you can come through a masseter approach. Either way, I'm not really excited about placing alcohol at the base of someone's brain. There are people who do that. Dr. Rogozinski does it. Those of you who know Dr. Rogozinski, that might not surprise you. He just, I will do it. And so, so yesterday we were having our pain meeting, our yearly pain meeting, and we needed a chair in the room. And we look up and Stan comes back and he's carrying a chair. He's got this put the chair down. What are you doing? And I've gotten the chair. So anyway, loss of corneal reflex. Yeah, you lose some of your corneal reflex. You have a motor deficit, so you get some sagging sometimes whenever you do a trigeminal nerve block. Carotid artery puncture, that can be a big deal. Retrobulbar hematoma and exophthalmos because of that. You have to watch that. And of course you can have infection because you're going up through the mouth in some way, shape, or form. Return of pain after the lesion, 54% at 4 years with glycerol, 20% with RF at 9 years. So that actually has pretty good efficacy. It's just a pretty specialized technique. You can't see the nerve, so you're shooting for a foramen at the base of the skull. It's kind of a risky thing to do. It's not an unreasonable thing to do. It's just you have to have a lot of skill in that particular procedure. Risk factors for shingles. This is just a grab bag of things that we've not done well on. Once again, it's a bad question. All Louisville Cardinal fans deserve shingles, so that's. Advanced age, African American, immunocompromised. So if you're immunocompromised, a lot of times in cancer treatment, shingles will come rip-roaring out. The elderly, okay? Stress, and there seems to be a predomination for African Americans. What happens is the virus will live in the dorsal root ganglion, okay? And so you get hyperesthesia at a dermatomal level. So these are the fibers, the white and gray ramus out to the sympathetic chain, sympathetic ganglion. It lives dormantly in that region and expresses itself under times of stress or immunocompromise. The elderly start to have immunocompromise, and that's why that happens. Anticonvulsants, antidepressants, single nerve root injections, stellate ganglion blocks. A lot of times we'll do an intercostal nerve block, just deaden the whole thing because it tends to happen on trunks. When it happens on the face, it's kind of bad. But it happens on the trunk, happens in the abdomen, pretty easy. Spinal cord stimulation. We now have dorsal root stimulation, which is coming out this year, that will work well for that. Phantom limb pain. Phantom limb is where you feel the pain in an extremity, even though it is no longer there. You have peripheral changes that cause that, and central changes. Whenever you get the slide set, I'll let you look over those. The central effects, you change in the glial function and sprouting and remodeling. The dorsal or peripheral, you get spontaneous impulses that are generated from the axons that are cut. There's also presence of neuroma and myofascial trigger points that cause a problem. Fibromyalgia. 18 trigger points, which you have to have 12. It's associated with depression, sleep disturbance, hypothyroidism. Symptoms are tender points, not trigger points. They are tender. They do not radiate. Okay? It is not articular. It is worse with cold, damp weather, stress or anxiety. It should not be treated with opiates. Okay? Avoid opiates unless there's a clear articular component. Muscle relaxants, avoid caffeine, balanced diet, sleep hygiene, exercise. Can use anticonvulsants. What is the difference between trigger points and tender points? Or there is a difference between trigger points and tender points. Tender points are fibromyalgia points, trigger points. Yes, trigger points radiate 3 to 5 centimeters away. You oftentimes get a sympathetic response. As you're doing a trigger point injection, sometimes people go, I don't feel so good. I feel like I want to pass out. It's not that they're wussy. It actually generates a sympathetic or a parasympathetic response. What happens is you have these fibers, muscle fibers, and they function like this. They move in and out. When they get disrupted, the cells break open. Calcium, potassium rush into the interstitial space, and the muscle, because these are neurally excitable ions, cause contraction of the muscle tissue. Okay? So you get calcium and potassium, you get depolarization of the muscle because of local irritation factors and because of changes in the ionic environment. So the muscle contracts around that trigger point in an effort to keep the damaged muscle fibers from stretching. So what you have to do is you have to go in and break up those muscle fibers. So steroids don't help, but local anesthetic is what? It's myotoxic. So it causes the muscle fibers to break down, and hopefully when they remodel in a more organized fashion. And also dry needling minces the tissue, which also causes it to remodel and reform. Okay? So trigger point injections use local anesthetic because they're myotoxic, and they also break up. Now here's something that is subtle and not well known. Each muscle group has a referred pain pattern. So there are dermatomal pain patterns, L5 down to the foot. There are sclerotomal pain patterns, so the facet joints hurt in a certain way to the back of the leg. And then there are myotomal pain patterns. So if you have a brachial plexus, or if you have a biceps muscle issue, you'll feel tingling down into the arm and over into the chest. I had a patient we did an axillary block on, and what muscle do you always inject whenever you're doing a transarterial axillary block? You inject the coracobrachialis to get what? The musculocutaneous nerve, right? In this particular patient, the neurologist said the patient was having dysesthetic, burning, hyperalgesic symptoms on the side of the chest wall. And the neurologist who did his EMG said, there's no evidence of nerve damage, but he has a clear block neuropathy. And I'm like, well, what dermatome was damaged by the block? You know, so whenever I called him, he said, well, you know, the guy's symptoms are classic. He didn't have this problem for the nerve block, and he had it afterwards. Well, we got a high-resolution MRI of his axilla, and he had necrosis of his corcobrachialis. And that was a myotomal referred pain pattern. If you look at corcobrachialis, it gives you a referred pain pattern into this part of the body. Why does the brain do that? Okay. When you have a heart attack, which I had one recently, so it was an interesting thing. When you have a heart attack, you feel pain in your left arm. Why? Because the brain has all of these muscles that it cannot give pain interpretation to. So it takes pain fiber information from the muscle, which is vague, and it applies it to a pattern that it already has established. It has established arm radicular type symptom pain. That's already hardwired into the brain. When the heart gives you vague pain, it tries to place it into some pattern that's close by. And so it says tingling and numbness in the arm, even though there's no abnormality in the arm. So whenever the corcobrachialis gets necrotic, you feel it on this chest wall here because the brain doesn't have any hardwired patterns for corcobrachialis pain. But it does have chest wall pain. So it gives you the next closest thing. So you get these myotomal pain patterns from various sources all across the body. So as you're thinking up block sort of issues, not everything is a block neuropathy. Sometimes there's other sources of problem. And the way you treat muscle derangement is just to get the fibers to reorganize whenever you have a trigger point that when you press on it, it radiates pain in a 3 to 5 centimeter distribution. Versus a tender point, which is just, ow, that hurts there, which is more the way fibromyalgia is. Fibromyalgia is not trigger points, they are tender points. CRPS 1 and 2, let me do this real quickly. CRPS 2, causalgia. It has a cause, a specific nerve injury. That's the way to remember it. The old causalgia, CRPS 2, there is a nerve injury, whereas type 1 is a caustic or a noxious event. If you twist your ankle and you start to develop global pain symptoms, that is RSD type or CRPS type 1. There is the Budapest Criteria, which is what I'm going to end on. Apparently CRPS is big in Budapest. You have to have 3 of these 4, okay? So CRPS, if you don't have pain, you don't have CRPS, okay? You may have sympathetic derangement, but you don't have pain. If you don't have pain, you don't have CRPS. It is complex regional pain syndrome. Sensory hyperesthesia, allodynia, you lightly touch the skin, it hurts. Vasomotor temperature asymmetry. So this hand is beet red and hot, or it's blanched and cold. This hand is sweating, this hand doesn't. Trophic weakness, loss of hair, nails, okay? And at presentation on examination, you have to have at least 2 of these. 2 of these have to be present the day you see the patient, 3 or 4 out of the 4 on history. I have had a history of sweating. I don't have that today. But there have to be 2 present the day you examine the patient in order for it to be CRPS. History of 3, presence of 2. And sometimes you get CRPS whenever nothing else fits diagnostically, but that's the criteria that you use to make the decision. Thank you guys for hanging in there.